Hi everyone, thank you so much for being here. My name is Naomi Inglar. I'm the Communications and Training Coordinator for the Tulane Center of Excellence in Maternal and Child Health and the Tulane Prevention Research Center, the two centers here at the Tulane School of Public Health and Tropical Medicine that are sponsoring the series this semester on health, racism, and communication. Little housekeeping, if you didn't sign in on the computers outside, please do. This will ensure that we get you the recording afterwards, as well as any follow-up information or links or resources that the speakers want to provide. Also, please do fill out an evaluation form. This is how we know what you want for next semester and future semesters. Also, I want to thank the student groups so much who have helped sponsor the 3 seminars this semester. I'm going to go over all 4 of them. We have the Tulane Society for Young Black Public Health Professionals. We have the Tulane Society for Sexuality, Health, and Gender. We have the Tulane Student Government Association for the Tulane School of Public Health and Tropical Medicine. And then we also have Salud for Latin American Communities. And 2 of those students will introduce our speakers.
So Becky Majdoch is a Tulane SPHTM alum. She graduated in 2002 from the then titled Community Health Sciences Department with a dual concentration in Maternal and Child Health and Health Education and Communication. She is currently the Health Education and Communication Manager on the Communications, Innovation, and Action team of the Bureau of Family Health at the Louisiana Health Department.
And Sumrita Bindra is a maternal child health epidemiologist with the Data to Action team at the Bureau of Family Health at the Louisiana Department of Health. And she graduated in 2013 from Tulane School of Public Health with her MPH with a dual concentration in maternal and child health and epidemiology.
Hi. So first of all, thank you for being here. It's not the easiest thing to make it to downtown in the middle of the day, so we really appreciate you being here. I guess I'm going to tell you about myself again. My name is Sumrita. I am an MCH epidemiologist at the Bureau of Family Health. I've been at OPH for a little over 3 years. I'm originally from Maryland, but I have a serious love affair with New Orleans, so that is why I'm here. I went to University of Maryland for undergrad, where I majored in community health, and then I came over to Tulane to pursue my MPH, and I was lucky to find a program that allowed me to study MCH and Epi. After graduating, I interned with LPHI for a little bit and worked at Arizona Public Health Department as a health disparities epidemiologist.
And I'm Becky Majdoch. I'm not going to repeat anything that you already heard, but I've been with the Bureau of Family Health for about 4 years now. Before that, I worked for the American Cancer Society as a health initiatives director at the state. And then I also did some smoking cessation early in my career for pregnant women, and at both the American Cancer Society and with Tobacco-Free Living Program of LPHI. And my undergrad is in biology and French from Hamline University in St. Paul, Minnesota. You can tell from my accent I am not from here, but when I go home to Wisconsin, my family also doesn't think I sound like I'm from there. So I don't belong anywhere. So I picked New Orleans, and I got the job that is exactly what I got my degree in, which is the dream, and I got to stay in a city that I love, so it's really great. So one thing we want to put out here right away is a disclaimer. So you might be saying, how did we get to be experts in racism, health equity, and communicating data? And we ask ourselves the same thing, because we don't consider ourselves experts. We just want to put that out there. We're the first to admit it. We work at an amazing bureau at the Bureau of Family Health that's really has a great leader that's allowed us to explore health inequities and do something about it. So we don't just want to explore it, we actually want to do something. And we're here as 2 people who are part of a team that's dedicated to incorporating actionable steps at the Bureau of Family Health into our daily work to make sure it's not just for show and that what we're doing has real impact. So we want to share with you what we're doing on our end to make it actionable by the learnings that we've had from national experts on the subject. Next slide, with that being said, I want to tell you a little bit more about the Bureau of Family Health because it's such a great place that we've been, that we work. We started off in about 2013. The Bureau of Family Health became a thing when the Maternal and Child Health Program and the Family Planning Program merged together at the state. And then last year, we grew a little bit more. We added in the children and youth with special health care needs programs to our team, as well as EMS for Children, and the Louisiana Commission for the Deaf, who actually recently just joined us this year. So we're a huge team. We cover a lot of different subjects, but we also see that racism and health disparities impact our populations really a lot. So this is our team, and this is our mission.
So our vision at BFH is to have healthy babies, healthy families, and just overall healthy lives. Our mission is to provide leadership, expertise, and partnerships to advance the health and well-being of women, children, adolescents, and families in Louisiana.
And ways that we do that is by providing reliable data and offering preventive and educational services, implementing and informing policy and educational initiatives, and building partnerships. So most of today's seminar is actually about that reliable data piece. Because what we do with data, it's not just putting it out there. Data is used by people, and they use it to make decisions about policies, about programs that they're going to implement, about even just generalizing about the health and well-being of our populations. So we know that that's really important, not just to throw the data out there, but to let you know how to interpret that data. It matters.
So we thought it would be helpful to start by looking at what's being done on a national level, particularly in the realm of Title V or the MCH block grant, and that's mainly where BFH receives our funding from. Also, just a disclaimer, we're going to be using the term Black in some areas and African American in other areas, and we're just using the terms that were used in the documentation or the data collection process.
We're actually not going to share a ton of data, but we wanted to put that out there because there's some debate, and I know that that's a question that's coming up, and we need to look at that in the future. So looking at what is happening at the national level, Title V, or the Maternal and Child Health Bureau at the national level under HRSA, they started looking at how maternal and child health is impacted by the life course theory. That health is more than just what happens, at the doctor's office, that it actually, or at this point in your life, it actually happens throughout your life. Your current health is impacted by everything that happened to you in the past. So, and not just everything that you put into your own body, but things in your neighborhood, societal factors, there are environmental factors and biological factors that all contribute to this, including risk and protective factors that you're exposed to throughout your lives. So life course theory is an updated and broader way of looking at health because it includes all of those things, and it explains how health develops over a lifetime, with health diminishing or improving based on risk and protective factors. And it illuminates the issues related to health equity and to place that you don't see if you just look at data specifically about health. And that actually was informed, the idea of looking more at life course theory in the maternal and child health populations was informed by Dr. Liu. Dr. Michael Liu is the head of the Maternal and Child Health Bureau, and in 2009 he and colleagues wrote a paper about how to, I've got to read the title of the paper, it was a 12-point plan to close the black-white birth outcomes gap from an ecological life course approach. So you can see if you're really serious about changing birth outcomes, and this is because the main call to action for maternal and child health is reducing infant mortality. That is one of the biggest things that we want to accomplish with the work that we do. You're not going to reduce infant mortality. I think we've hit what we can do if we just focus on preconception, prenatal care. You've got to look beyond that. So you need to first look at the bucket of things that are like providing interconception care with people who've had adverse pregnancy outcomes. access to preconception care for African American women, because access is an issue, looking at improving the quality of prenatal care and expanding health access over a lifetime. And those points take you out of just healthcare needs, but also talk about healthcare needs for Black or African American women between pregnancies and across the life course. And the next 4 points move beyond our current focus on the individual risk behaviors and begin to address family and community systems. So these are strengthening father involvement in African American families, enhancing service coordination and systems integration, creating reproductive social capital for African American communities, and investing in community building and urban renewal. So you wouldn't really think of that if you're just thinking babies and helping babies live. And the last 4 points really move beyond the current focus on the biomedical model and address the social and economic inequities that are the root cause of a lot of our health disparities, which are the education gap and closing that, reducing poverty, supporting working mothers and families, and undoing racism. So it is really calling out, in 2009, he started really calling out the things that we need to do if we are actually going to see a shift and start moving in the right direction when it comes to reducing infant mortality. And in Louisiana, health disparities by race are a really significant issue. We have a lot of factors that contribute to racial health disparities, and the root of many of these factors is racial bias within organizations and institutions. These things are not necessarily, they're unintentional nowadays. They may not have been unintentional when they were built out, the policies that are in place today, but the ones that remain today are, I don't think people even realize the historical background about why that policy is in place unless they've taken the time to look into it. So this type of racial bias is institutional racism, and it's often unintentional by the people who perpetrate it today. We commonly think of racism as individual acts of bigotry, but the Bureau of Family Health has been really digging deep into this and acknowledging that policies, protocols, and other operations of organizations can unintentionally benefit certain groups over others. So we're committed to learning more about the ways we work to ensure that our work is equitable and avoids this unintentional bias. And thanks to the leadership of Amy Zapata,
That's who the picture is of.
our fearless leader, we've really made some headway. I mean, she's really challenged us to change the status quo.
And then changing the status quo is not easy when you work for a state agency sometimes. Many of our coworkers know this because it depends a lot on the political climate and who's in leadership and the boundaries that can be pushed. So we have to be really mindful about timeliness and readiness to make changes.
And just one example, I don't know how many of you know, but the Bureau of Family Health is under the executive branch of government. That means every single time we get a new governor, the head of our department is appointed by that governor. So every time there's a leadership change at the executive level from an election, we could end up with whole new policy focus and shift and leadership at that level. And it does trickle down, not as much at our level. We can still do our work usually, but it does make a difference about what we can say and how we can say it. So with health equity, what we started doing at the Bureau, thanks to Amy, was learning. She wanted us first to make sure that the staff had a real understanding about what racism is and how it impacts health, and really believe that it's true, because that is the first step, is that people believe that it's true. So some of the things that we've done are trainings and workshops. So we started, we went to Undoing Racism workshops, and we've had ongoing journal club. We watched documentaries about the subject together, and we have had other ongoing trainings specifically about communications and health disparities, which we're actually going to reference later. And then we've also instituted a standing internship where we have an intern who looks into the historical drivers of racism, and typically that students come from Tulane. And the current, Brianna, sorry, that friend. The current, sorry, got totally distracted. The current leader of, or current student in that role is Grace Saul. So yay, Grace. They're actually having a meeting right now, and Show Cafe works with us on a team called the Health Equity Action Team that the intern also works on, that is charged with writing a plan, an action plan to make these changes into, like, build them into our system. So say Sumrita or I leave, this still happens. Okay, sorry, I totally got distracted because of that. So today, let me just look at my notes. I'm apologizing now. We want to go into some of the specific rules about the Health Equity Action Team at the end. But that team has allowed us to put some processes in place to make sure that we review data and report it to make sure we're framing it appropriately. And the training that we do as part of this health equity framework that we've put in place at Bureau of Family Health is ongoing, and it's really built into all of our professional development goals and objectives. And I was going to tell you a story about one opportunity I had that really, I went to this session at a conference I attended, and it was a perfect story for this seminar. So I wanted to share it with you. It's from the CDC. I was at the National Conference for Health Communications, Marketing and Media, and they were talking about a report that they were about to put out that they realized might not be the best report in the world if they just put it out there. So this is a little bit about why framing your data matters from a national perspective, and just know that this conversation is happening outside of the Bureau of Family Health at the national level. This isn't about African Americans this is about health inequity in lesbian, gay, and bisexual youth, and stigma. So stigma can happen at any level, and this story in particular is one that I heard and I wanted to share, because the CDC admitted they've seen their role as analyzing data and sharing the statistics in data reports. That's it. They analyze it, they put it out there, but they typically have not worked with their communications team to build out their report, only to publicize that the data are available. So there's a press release that goes out that says, look at this great data that's available. They were about to put out a report about sexual identity in youth and how that translated to risk behaviors that they were seeing in those youth. And it had something in the title about sexual minority youth and risks in sexual minority youth, and it was going to go into the Morbidity and Mortality Weekly Report. And just before the communications team was about to push out the, hey, look at these data that are about to be published, somebody there said, wait a second, this says that there's a lot of bullying, there's a lot of violence, there's a lot of sexual violence happening in this population. Maybe we shouldn't just put out sexual risk behaviors in sexual minority youth as our title. That would be doing that could potentially stigmatize this population that is already having risk behaviors that are related to the stigma of just their sexual identity. So they said, wait, and let's pull this report and not print it. They decided not to print it at that time, and they really pulled together an interdisciplinary team at the CDC with leaders. It's hard to get leaders in a room at the Bureau of Family Health or the Department of Health here, so I can imagine it's like 20 times more difficult at the CDC to get people of that level together. But what they did is sit together and really look at how can we avoid stigmatization of these youth and still put out the valuable information that we learned, and how do we frame that data to make sure that it's meaningful and doesn't cause additional harm to our population. And they're already vulnerable and stigmatized. So what they did is they really pulled together kind of they made a message wheel kind of thing with like an X, and they put like the main things that they want anybody who looks at these data to think or come up, like the main messages, and then what are the data that supports those messages that they wanted to put out. And then instead of putting out one big report, they actually decided to put out small reports about those specific topics. So there's a whole report just on bullying. There's a whole report on sexual violence. And those have graphs that go along with it. It's interactive, it's digestible. And then they also put out a press release that was built to not stigmatize the population. So for the first time, after bringing all these people together, they were able to get actual real positive coverage that said what they wanted people to see in the data. They weren't making anything up, so there's that too. You have to be really careful. It's a fine line between like making inferences that aren't true and walking people in a direction that is not, that's maybe biased on the other end, and then also walking in the direction of just, here's the data, you decide what it means.
Because there is responsibility with how you share data, and you can steer the audience into what you want them to see.
So when they first released it, they ended up getting only positive coverage. And the positive coverage, here's the headline that they put out on their press release. And you can see that it's not stigmatizing anyone, it's telling the facts, but it's also saying that we need to do things to protect the youth. That's an actionable item. You can't just, they want you to realize that the CDC wants something to be done. They don't want to just keep reporting on bad data over and over again. They want to see changes and shifts in these bad things when they notice them. And I know I'm putting value to it by saying bad, but bullying's bad. I think everybody can agree with that. So not only did they put out this title, they also put out these charts. And you can download any of these charts individually if you need them for reports or anything. It's great. But they didn't just say percentage of high school students. They tell you what you need to, if you're looking at this graph. We're so used to seeing the graph without this piece. And I'm covering, for anyone on the recording, I'm covering up the piece that says lesbian, gay, and bisexual students are more than 3 times likely to have ever been physically forced to have sexual abuse or sexual intercourse. We're not used to seeing that piece, so you don't know what to think about just looking at a bar and you're like, okay, look, high bar, low bar. I guess high is bad, but I'm not very sure. You have to really force yourself to like interpret it. This is interpreting it for you, the thing that they would want you to see. So that I just wanted to share because it made me think a little bit about the work that we do. What we do is we're trying to move away from just individual and community level work. We're trying to make impacts at the policy and systems level, and data and communications are really strong ways to do that because you have to influence people with power to make those kind of changes. So from that example, you can see that you need a lot of different sectors involved to make a difference and make a change. And so that's, you all are aware of socio-ecological model and the social determinants of health. The other thing is you can't have a big systems level or a societal level change unless you actually address the social determinants of health in the work that you do. And that's how we need to look at our work. We can facilitate that shift to the outer rings by the way we communicate our data. And since I'm on the Communication, Innovation, and Action team, I'm going to look a little bit about the communication side of this with you on the next couple slides, and then I'm going to ask you guys to chime in with some thoughts about how to change a headline. So, word choice. The words we use matter. From the trainings and workshops we participated in, we know that that matters and that it's not just in ads and press releases. It matters in data reports and other materials, and it matters to internal and external audiences. You can't jazz something up for just the outside folks but not realize that some of the people that are inside are also, you know, appointed positions. We've had people in the head of our communications department at one point who had a fashion design degree, for example. So you can't assume everybody has a degree in public health who you're working with just because they happen to work for the health department. Robert Wood Johnson put out a guidebook on how to communicate the social determinants of health to non-public health people. These are all some of the topics that come up when we're talking of social determinants of health. But you need to know that Americans typically have some mental shortcuts. Every culture does, but I'm going to talk about American culture because that's where we are. We have mental shortcuts that we make when we hear certain words, and the mental shortcuts can distract the consumer, whoever is hearing the message, that from the overall message and what you're trying to get across to them. So if we tend to err on the side in American culture of individual responsibility, you know, you can pull yourself up from the bootstraps, it's your own fault for being in such a bad situation. We make exceptions for that for small children, but once that child becomes a teenager, it's like, nah, maybe they could have made better choices. They're practically adults. So we do stuff like that all the time, and we also give less importance to the role of systems and institutions in the way that health impacts our health, our own personal health. So because of this, these are some words that we should avoid because they all have subconscious associations. You might not think, but some of them are more obvious than others, but every single one of these words has been identified as a word that could turn somebody off or have them stop listening or start thinking, well, why didn't that person do something better? So we have to be mindful about the words that we use. And we have to check ourselves as public health professionals. We're so used to talking to each other. Trust me, you may feel like that in school, but once you're out working in public health, it's even like 20 times worse. We use public health speak all the time. I get sick of ourselves sometimes, and I'm guilty of it. So we have to remember that when we're outside of our own bubble, that it matters, and you're going to turn people off, or they might glaze over. So really be careful. And when you're mindful about the words you use, it makes a difference. So think about health disparities. How do we say that in a way that you think those people just don't try hard enough? They could live in a better house if they tried. They could get a different job if they tried. You hear that in like even tobacco world. It's like, well, work somewhere else. Easier for you to say. So I'm going to go through actually how to swap out one trigger word, and I picked vulnerable. So vulnerable means like vulnerable populations. And when you think about a vulnerable population, that usually means people at risk who don't have the capacity to make changes on their own, either because of their age or their educational level or their abilities. And but for most people, that triggers a feeling of otherness. It's someone else. I feel bad for them, but I don't know what we can do because they're already so other. And so we have to remember that otherness makes a difference in how people want to help. They don't know what to do. They feel helpless, so they're not going to do that. That spurs inaction rather than action. And that happens a lot with people outside of public health. So here's what Robert Wood Johnson says we should say instead. Instead of vulnerable populations, sorry for the very slow animation, people's health is significantly affected by their homes, jobs, and schools. Vulnerable populations is now everybody. It's not my favorite. All lives matter is not cool. But this is a way to bring people in and feel like they might be an other at some point in their lives. We've all been a child. We're all going to get old, hopefully. So there are lots of ways to make people see that this is a part of their lives too, and it matters. So from our experts, we've learned that we should choose our words in a way that individual is replaced by a system or a policy that might be the underlying cause. So on this choice, it's homes, jobs, and schools. Those are outside things, not just the individual. And on the next slide, I'm going to look at some different ways to say some of these things, and this is where it becomes your turn. Is this when we have to pause? Not yet. Okay, good. We're doing good. Okay, good. All right. So, like I mentioned earlier, I wanted you guys to look at a headline that's a real headline and tell me what's problematic about it, and maybe we can fix it. That contains some trigger words. But we all love a good clickbait article. I mean, who doesn't? I know that's what gets me to click on something in social media. And we don't want our stories about public health things to be buried either. So this is one thing that we really have a challenge on our hands to make something sound good enough that someone wants to click on it and read about it. Because not reading it also is not going to make a change. So the next slide, I'm going to put on that headline and have you start calling out. Just say it one at a time, and I'll repeat it because we're recording this, so I want to make sure that whatever I hear from the audience is recorded as well. Here's this article called, I'm just going to read the top of it, but Bad Connection. Teen girls with smartphones flirt most with depression and suicide. And then it's got a subheader about suicide rates paralleling the rise of smartphones, especially among teen girls who are most vulnerable to cyberbullying and alienation. And this is a real article from the Daily Beast. So I want to hear from you guys. What are some trigger words or some problematic parts of this? And yep.
So vulnerable to cyberbullying almost makes it seem like it's the girl's fault that she's the one getting cyberbullied.
Okay, so for everybody to hear, being vulnerable to cyberbullying, it's her fault. Okay, I saw back there in the back.
The word flirt, it kind of romanticizes the idea of depression and suicide and makes it sound like it's positive.
Flirt romanticizes depression and suicide.
For me, the word flirt, again, made it sound like she was asking for it.
She was asking for it. Flirt, more about flirt. She was asking for it. Anybody else have strong or other thoughts about, just about flirt? That's the one that really got me too.
I think especially here, teen girls and flirt.
Mm-hmm.
They're also in this
Yeah, teen girls and flirt. So these are the ones that I caught. Teen girls. What is problematic about teen girls? They were one of the others on the list. Does anyone have any thoughts about what's problematic about saying teen girls? You get a specific picture? Like, what do you picture? Yeah. You start picturing this privileged teen girl with her phone. And she's flirting with suicide. So, and then if you really look at the bottom paragraph, it's, to me, this whole paragraph, what do you guys see as a problem with this? What do you think I think is the problem with that bottom paragraph? A spike in teen suicide rates parallels almost exactly the rise of smartphone use, especially among teen girls who are the most vulnerable to cyberbullying and alienation. Yep.
It says it's parallel, but it doesn't say, like, one caused the other. It just said it's, they have to do the same thing.
Yeah, so they're parallel, but
What is it?
whose chicken or egg situation? What caused it? Is it having teen girls having smartphones, or is it cyberbullying and alienation?
I think there's all teen girls that are saying that they're all vulnerable to cyberbullying and alienation.
It makes all teen girls vulnerable, and it doesn't it groups the whole population together. Alex.
And also the smaller paragraph says teen suicide. It's not just talking about girls. So with the title specifically saying teen girls, it alienates someone who doesn't identify that way. Like,
That's true. So it doesn't. If someone doesn't identify as a teen girl, the subtitle doesn't. It talks about suicide in general. I'm trying to sum it up the right way. It talks about suicide in general, but it doesn't acknowledge that not every person who commits suicide, who dies from suicide. Sorry, I had to fix that. Trying to learn this one. Someone who dies from suicide it's anybody, but then it's about teen girls, so they're not really parallel in the grand scheme of things. Any other thoughts? One more. Yes, it does not talk about the villain in this story. Most stories have a villain, a victim, and a hero. This is not one of them. So that's actually a really good call. I actually didn't notice that. So I put better headlines together, but that is a piece that's missing, and I would love it if anybody had an even better idea for a better headline. So as you can see, someone will click on this and read it because it's sexy, the girls are flirting, but they're probably going to read a story all about how, if girls weren't on their phones so much, they wouldn't be making themselves vulnerable to this cyberbullying. How dare they want to, have a phone? How dare their parents buy them phones? Whatever ... you want to make for that, but that we're all making some sort of mental ... when it comes to this article.
And a lot of us don't even we'll read headlines and take a message from the headline. We don't even actually read the whole story. So.
I'm very guilty of that too. Or I'll click, I'll read the first 2 paragraphs, and I'll be like, this is too long, I'm done. So that's how I consume these days. Okay, so there are ways to fix this. And I just want to call out a few of them. Just remember that we have mental shortcuts. We all have biases. We celebrate individualism, and we love a crisis. So that was all of the above. There was a crisis there. It was about those teen girls. Those are the individuals. And there was a lot of implicit bias about teen girls in our brains. There is a way to make headlines that are clickbait worthy but don't stigmatize anyone. And one way is to provide solutions. So remember the CDC headline? There was a solution there. It was accelerated action is needed to protect vulnerable youth. It was still a very high level. What does accelerated action really mean? But CDC is making an effort. It's moving in the right direction, so we got to give them some kudos for that. They probably could have done it a little bit better, but it was good. That was the solution, and it compelled action. So those are some things that you can do to fix these. You provide a solution, you compel some action. They didn't offer any solutions in this except for maybe ban teen girls from using smartphones. Like that would be, from that headline, that would be like one way to fix it. And lawmakers do that actually a lot. They'll see a headline, a sensational headline, and they're like, oh, we've got to stop the teens from the smartphones. Let's create a law. Let's put them in jail. And then they won't commit suicide. So just remember that. Be careful about how you frame it that way because it happens. You also need to call out some of the systems and structures, context, and the environment. So making it less about the individual and more about the systems and structures is a really good way to do this too. And then also to talk about place. So this is my attempt at fixing this headline. I made it all one headline instead of having a sub-headline. And this was I did this quickly. Again, like I said, if you have a better one after this, I'd love to hear it. Combating cyberbullying in the age of the smartphone can save lives that are impacted by suicide. We owe it to our daughters. So with this, I tried to offer a solution. The solutions are combating cyberbullying and saving lives. So if you combat cyberbullying, you can save lives. And then I'm calling out the environment, the age of the smartphone, so that we're all living in this age. It's not just teen girls who have smartphones. We all have smartphones. Let's be real. My dad has a smartphone. He thinks people are messaging him personally on Facebook, but that's okay. It's cute. And then it also takes out those trigger words of depression and teen girls. It doesn't take out suicide, and that's deliberate. I thought about taking out suicide, and I'm like, that's not fair because this article is about suicide. Sometimes you have to choose what word you want to include, but don't have all the trigger words so that that one word means something and it has more impact. So, and then owing it to our daughters was a way of, since we're Americans and we like to personalize things, it took out that otherness of just those teen girls. It's like our daughters. We have something to do with this. So let's just, I'm wrapping up my section. I just want to make sure that I got all to this. So it keeps the intent of the article to share the data on suicide rise in teen girls, and it's correlated to the increase of smartphones. And now that I've talked a lot about words, and I'm tired of hearing myself talk, I'm actually going to turn it over to Sumrita to talk data.
All right, so let's talk about some skills that we can use when we're presenting our data. So when we get our hands on some data, we'll usually want to clean it, analyze it, and then present it. And we'll usually subgroup our findings. We'll use subgroups like income, age, gender, and race, usually without even thinking twice about the implications. And we really could be perpetuating the racial disparities that are already in place. So before we get into how, let's establish that numbers are powerful and the way we present them is even more powerful. And for people who do handle data, it's our responsibility to be ethical and mindful when we present it. So here is a graph that you might see in any data report. This is actually from the 2012 Census Annual Report. So let's break down the structure first. Looking at the color, is there anyone see a problem with it? Yeah, go ahead.
I feel like we've been battling with like racial like classes in America, and by presenting data that's saying where like one race falls, you're kind of not really mentioning the social pressures and like factors that go into why those races. So you could say like, you know, people below this line are inferior because of their race,
Right.
and it's like we're treating people inferior.
So we're setting up people against each other to some extent. I'm going to come back to that one. But the fact that this graph is green, this could be really bad for people who have visual impairments or they're colorblind. It's not the best color. To be fair, this was actually a blue graph. I changed it to green to make a point, but regardless, even the blue wasn't that great. The second thing about this, if you if you look at the title, it says real median household income by race and racial and Hispanic origin. What does that tell me? Like, okay, it's something to do with median income. Okay, it doesn't really tell me much. So your title should be useful, concise but useful, and it should highlight a key finding. So step one, make sure your audience can see your graph. Second of all, make sure your title is saying something. So if we look at the content, so let's say I'm someone who's allocating funding for a program, and I'm looking at needs. So I see the Asian population up here. Okay, they earn the highest, and despite, I don't think you can see this, but there's like lines up here that show recession. So even when they are hit with recession, they're still earning the highest. So I guess they don't need the money. When you look at this argument, you really missed out on all the context, which is what you were talking about. First of all, Asians is a very large group, very diverse in income and needs. And I'm going to talk about all the groups, but my reasoning applies to pretty much all groups. They're very diverse, their income needs are different, so we're actually hindering people who might need the money and who might need the help, I guess, from getting what they need by grouping people together like that. And then when you're putting this line up there, you're actually in some ways reinforcing the Asian model minority myth, because you're actually setting up groups to be compared against each other, and you're creating this hierarchy of who's better or who's not.
So, do you know in this data if they included the parameter of how many adults are in one household?
No, I'm going to come to that. So I'll come back to that, but they also say nothing about immigration policies, and which we know dictates how our communities look like, especially our minority communities. And then third of all, it's the household makeup. Like, we don't know what the family size is, and that again goes for all the groups. Maybe that income is really high, but a lot of Asian families have multiple people, many people in their family, so that income might not be cutting it. So then we look at the white non-Hispanic population, and then looking at this graph, we don't know if this is based on one income in a household or multiple. So let's say in the white non-Hispanic groups, there's only one person earning, versus in that Asian group, there's two people earning, which is usually, in statistics, that is the case. But let's say if there were two people earning in the white household, their numbers might look pretty much very similar to the Asian group. We don't know, we're just speculating here. And then we look at the Hispanic and Black. We see that with the Black population, you can see how their income has increased over the past 45 years. We can speculate why that is, but again, we don't know for a fact. And then for the Hispanic population, you see how much it fluctuates. And again, we don't know why that is. Even in this report, there was no context given. Pretty much this is all it showed for median household income. And I think it's just general nature to look at individual level factors when we're trying to fill in the blanks for information that we don't know. And we often will lean on stereotypes or assumptions to explain other people's behaviors and their situation, as Becky was saying. And that's why context is really important to back up the data.
Sumrita, I just want to throw in there too that the census gives you so much, and this is what they choose, how they choose to report it. It's kind of sad because it's rich data. There's a lot you can do with it. You have the concentrated disadvantage. That's all census data. Just if you do it in the right way, it works. And Dr. Thiel can tell you all about concentrated disadvantage if you want to know more.
So having that context actually fills in those blanks that we don't know. So the key message here is data has a power to either engage or alienate populations because it can actually encourage audiences to focus on individual level behaviors as opposed to systematic issues if it's not presented with appropriate context. So we're going to look at what context looks like. I'm going to go over historical, structural, and cultural. So we have to admit that we're products of our history. It's really important to understand our history to understand what our current health outcomes are like. So we need to, let's look at redlining, for example. For those of you who don't know what redlining is, it was a way to segregate based on race, and certain communities were labeled as desirable or not based on race. So on this map, the blue right here are the white communities, and they were desirable. And the yellow and red, hard to see that, it's red, but the yellow and red are declining communities, and often the communities where people of color lived. And like this practice is completely illegal now, but the effects of this are still, we can still see them in our data. So when you look at this, these communities often had low access to care, low quality of care, just a lot of poverty, a lot of generational poverty, and just overall instability. So we also know that New Orleanians don't have the best health in many areas, but take a look at this map and see how much red and yellow there is. It kind of speaks for itself. And this, stuff like this, feeds into our story of what we try to tell with our data. Next, we'll look at structural. I'm going to use this graph from our 2014 Reproductive Health Needs Assessment at VFH. A large majority of our respondents to this were females under the age of 30. So you can see a lot of them have had conversations with their doctor about family planning and just contraception, but see how many have talked about birth spacing with their doctor. 74%.
Have not.
That's not a lot. So in order to understand the reproductive health needs of our clients, potential clients, we need to understand the structure that's there and then the gaps that may be there. And that's where this comes in. So it might not be just that these women just want to keep having babies or they're just getting pregnant quickly for whatever reason. It's because they haven't talked to their doctor. There's something in the healthcare structure where they might be getting educated by their healthcare provider that's missing. There's a gap. Also, it's almost 12:50, so if anyone needs to leave, please go ahead. Although we'd like if you stay.
We understand if you have class.
I see this. All right, so this is cultural context. Cultural context will always give us insight into communities and why they do they do the things that they do, and why, like, it gives you the heart of the data. So this quote is from our PRAMS respondents. I'll go into what PRAMS is in a second, but usually we'll put out data-heavy PRAMS reports, and we've started including these quotes to add more context and to drive the points home. So these two quotes, I know it's hard to see, are about breastfeeding. We see that social structures often influence how and if and how long the baby is breastfed. So this mom over here is talking about, I'll just read the quote. I believe that some cultures are not supportive to mothers who choose to breastfeed. Their mothers didn't do it, so they don't. Also, I notice in some cultures, the baby is the responsibility of the maternal grandmother. This also creates a situation where breastfeeding is impossible. Our other mom says, this is our second child. I already knew about breastfeeding. I'm still breastfeeding. I have great breastfeeding support group. It consists of other mommy friends, my husband, my family, my husband's family, and especially my mom. She was La Leche League for 15 years. So your cultural structure environment makes a huge difference as well. Now I'll show you some of the changes that we've made with our work that we do. So our Bureau's vision is to present data in a way that illuminates the social determinants of health that contribute to the disparity that we see. These pages are from our annual PRAMS reports. PRAMS is the Pregnancy Risk Assessment Monitoring System, and it's a surveillance system that captures maternal behaviors before, during, and after pregnancy. So we redesigned our PRAMS reports to highlight the intersections of social determinants of health, public health implications, and to better engage our stakeholders. And so our 2012 report, 2011, I'm sorry, report in the back is literally a regurgitation of the numbers. It's like the question is right here and then the data findings. There is this section on key findings, but overall it relies on the reader to extract meaning out of it. So our new report, this is from our 2014 surveillance report, which is also online if you ever need to get a hold of this report. It's great. There is more context behind what we're showing here. We added this introduction section and a public health implication section right here. So it makes the information more digestible to the reader, and the reader isn't left questioning, why are we looking at this? We answer the question, so what? Alex?
I can't really, I guess I can go look at this later, but I guess for now, can you tell me what are some of the ways or like phrases or manners of speaking about the like top level forces that go into creating, kind of social determinants of health stuff, like giving people the context for your data along with, or as a part of making it more digestible and like giving them that context about like why certain populations have certain outcomes?
Yeah, so the question is how to talk about, how to frame what you're trying to say, how to make it more digestible, is that right?
And call out
specifically regarding, like racism, classism, like how these things are impacting people's health when a lot of times, like, they're not really measured or accounted for in a way that a lot of public health professionals are comfortable with.
And this is sort of groundbreaking stuff, so there is sort of a lag in adopting new practices.
Yeah, I was going to say, I think it's a work in progress, and
Yeah.
you'll see that when you see our Health Equity Action Team plan. I think that we recognize that that's a gap that we have right now, and we are trying to figure out how to do it better. So, yeah.
But I think Robert Wood Foundation does have
Yeah.
like how to talk about. Do they? Or am I making?
Yeah, there's Robert Wood Johnson Foundation. That's kind of where I got the slide with all the words on it. They have it's about how to talk about social determinants of health. But I see what you're saying, because that report kind of skirts around racism. It doesn't really address it very straight on. So it's still we're trying. We'll tell you what we're doing a little later. Stick around.
All right, so this is the second page, another page from our PRAMS reports. So this one looks at breastfeeding, and this is our old report with our key findings right here. So we know with breastfeeding there is a large disparity in races. However, instead of just highlighting that disparity, we found it necessary to look into factors that feed into that disparity. So you'll see here, sorry, you can't see it over that side. We have the section on breastfeeding readiness and preparation prior to birth, and we broke this up by race, and this was a very conscious decision to do. It added to the message that we were trying to send out. Here's the second page of our new report, and here we're again highlighting race. And that's because we want to show racial differences when it comes to provider-patient interactions, and how there are deep-rooted biases in healthcare delivery. So in this, you see that Black infants were more likely to be given pacifiers when they were in hospitals, and they were more likely to be sent home with formula gift packs compared to white babies. Which we know negatively impacts breastfeeding in the long term. And then, as I mentioned earlier about the quotes, this is a really powerful way of engaging our respondents and making sure that their stories are not lost in the numbers, but they add value and they enhance the message. So, key message, stratify only when it's necessary. I think it's good to stratify while you're trying to see the trends, but when you're presenting the data, be careful about what you're stratifying and putting out. And then think about the message behind the data. There's more to numbers than just presenting them. And it's our responsibility to give voice to our respondents in a responsible way, and explore and experiment with different types of visualization techniques. All right, so I'm going to get on to pictures now. A lot of data reports don't have pictures, but in general, we'll use them either for a presentation or something or another, and pictures matter. All right, so first of all, be critical of the pictures that you use. Be mindful, especially when talking about sensitive things like infant death, suicide, sensitive topics like that. So I find this one to be really interesting. This billboard, I don't think everyone can see it, but it's from the Mayo Clinic, and it says, "She never gave up, so her cancer did," because she willed her cancer away, and she was just so strong, unlike the other cancer patients, that cancer just left her body, I guess.
And she's all smiling and happy in the picture out in the nature, and yeah.
Great.
Yeah. We know these are ads, but I think when you see photos being used in public health reports, we've all had a moment about some of them, like, really, that's the picture that you went with? So with infant mortality, we've had ones. Were you going to talk about that?
No.
Yeah,
Go
so we had, at one point, we had a SUID fact sheet that had a picture on it, or we were going to put out a child death review report. We were trying to decide if we wanted to put a picture, and like somebody had proposed having a smiling, happy baby on the front. I'm like, of the child death review report, it's like, look at these people who lost their happy baby. Or an empty crib, which is just really depressing. I mean, it's a little closer to where you want to go, but that also evokes just like the, oh my God, helplessness, trauma, sad, empty. And so sometimes no picture is the better choice, and other times it's like find a picture that is right for it. Definitely not smiling kids on a death report.
There's an example that I saw online about someone who was trying to work with American Indian communities who was talking about some sort of justice or something using the scales, you know, like the scales, as like a picture in their report or whatever they were using. And there's a really strong dislike for scales among American Indian communities, apparently, because they were cheated out of their land by settlers who unfairly took their land because of the way things are weighed. So, all right, so let's shift gears a little bit. A group of us received some funding from AMCHIP recently around data visualizations.
The Association of Maternal and Child Health Programs.
Yes, thank you. One of our assignments was to redesign a graph. So we found this one from March of Dimes, and it looks at the uncomplicated, the cost of uncomplicated versus premature or low birth weight compared to all births. And this is keeping the cost for the employer in mind. I'm going to go over some design techniques. While doing that, I want you to keep thinking about how you would redesign this graph. So first thing, pick an appropriate title. As I said before, it should show, it should summarize. I'm sorry, I read that wrong. Pick an appropriate graph. Look at the type of data you have. Say if you have pre-post data, you could do 2-bar graphs, but it might be more interesting to see a slope graph because you can visually look at that and immediately see the increase or decrease or no change. Highlight a significant finding in your title. Make it easy for your audience to know what you're talking about. Answer the question, so what? Use a color scheme. Use colors strategically to draw the viewer's attention to what you want them to see. And if you work for an agency that has a color palette, use the color palette for branding purposes. Keep your audience in mind, like the green that we talked about. Use colors that are not going to be problematic to people with visual impairments. Use text that's legible for people of all ages, and language that is easy to understand. And order the data intentionally in a way that makes logical sense. So if you look at this graph, it's really interesting how this is right in the middle, even though this is what you're trying to show. Oh, I kind of gave that away.
Okay.
Any ideas how to redesign this? Anything? You worked on it. Tell me
Does
something.
anyone have a better title? Show cafe.
I mean, I feel like the message of the importance of trying to aim for uncomplicated births is sort of lost because you're so focused on the high price of the premature. And so, to me, the take home is employers should invest in their employees so that they can have uncomplicated births. But that's sort of
That's exactly the message we were going for, but
in the
Okay. So to repeat for the microphone, what did you say? Employers should invest in their employees to reduce the cost of complicated births.
right
Something
to aim
like
for
that.
those uncomplicated.
To aim for the uncomplicated births. Okay.
okay.
I can see why Shokafe would think that through her lens. But what it seems like to me is that it looks like employers are taking a hit really hard from premature low birth weight.
Okay, so employers are taking a hit from low birth weight.
They have to work out all the cash for this.
Because your eye immediately went to this, right? You saw the high cost of premature low birth weight. Okay. So I'm going to show you our redesign. And I know it's very simplistic looking. So if you look at the title, investing in women's wellness can cut employers' birth-related costs by 1,233%. This almost looks clickbait. I know the title it's very clickbait worthy, but it's useful and it grabs your attention and it summarizes the message that we're trying to send. We decided to stick with the bar graph because it worked with our data, but we did try out at least 5 different graphs before we picked this. But we did add this line showing the average cost of birth to create a comparison. So it's easy to see, just looking at it, that uncomplicated births don't cost as much as average. And we used the color very intentionally to draw the viewer's eye straight to that blue. It's almost like a highlight for this graph. And then we also did put in some language around explaining what our title is saying.
So we also are open to, if you have even better way of saying it, this was our homework for a project we were on, so we're done with it, but
it's still good to learn.
Yes.
Go ahead.
Something I'm curious about, when you add the average cost of birth line there, it is bringing in like the perspective of what is the rate of premature low births to like uncomplicated births as a whole. So I think rather than just giving the average cost, it could be more helpful to say like these are the number of, or this is the percentage of premature and low birth weight births to uncomplicated birth rates, because the average
It's
kind
not.
of gets that, but it's not super clear.
This is, it definitely doesn't tell you how many births are uncomplicated, how many births are premature or low birth weight, or how many births are considered average in this graph. But we didn't have those data to go with. We had to use that, just what we were given from March of Dimes.
How is the average number? Where did you get that from then?
It was from that graph before on the previous page. We found that graph, and our charge was to make it better, given the information we had. So
Yeah,
we were allowed to make some stuff up if we wanted to, but another part of data visualization is keeping it simple too. Like, she actually doesn't love if you have like dollars and percentages and something else all in the same graph. And by she, I mean our technical assistance person. So I know what you're saying.
Well, I guess I'm just confused as to where that number would have come from then, because it seems like that would.
the average birth number.
Yeah.
Oh,
It was there.
It's
So
right
no,
here.
I mean, like for all births, is that basically? I guess I'm just confused based on looking at this. If all births then is like a lump sum of all the premature and low births, and then all the uncomplicated ones, and it's just taking an average based on those.
I
Is
think
that inclusive of the other?
so. They didn't actually specify how they. Yes, you're right. So we don't know how this was calculated. We just redesigned this, but I would assume that it's like the average of the two.
So it's taking into, that is where it takes into account that maybe there are only 2 premature births at that company, and that the majority of them are uncomplicated. But look at how much, just it could be $4,389, but just a couple of premature births can make that much of a difference. It can triple how much you spend on birth costs. I think that's maybe.
Yeah.
I mean, obviously, we know that this is not perfect, and you're calling out something that we probably, if we were redesigning it again, needs to take into account. Sorry, Sumrita.
It's okay.
You're the expert.
All right, so takeaways. Do consider this story or idea that you're trying to illustrate. Do try to balance the quantitative or the qualitative data. Do include a summary and an implications section. This really helps the reader who maybe just speed reading your report to leave with a message. And don't be afraid to challenge traditional data visualization techniques or stratifications. Sometimes a lot of us data people are stuck in our old ways, so there could be some resistance, but keep trying. And don't overlook the fact that images can enforce stereotypes or be offensive. So you should always ask yourself, is my image deterring from the message or adding to it? And don't use colors excessively. Having consistency in your color palette is really important for the eye to just move through your graph or your whatever you're presenting.
All right. So we want to wrap, so those are some like practical skills and some theory behind how you frame your data matters and some ways that you can do it a little differently. And as we said, we're not experts and we're still learning. So we also wanted to tell you some practical things that we're doing at work to make this happen and actionable. Again, we don't want to be like a small team of people who really care about health equity and racism and changing structural and societal level things that impact health, and then if one of us or all of us end up leaving and moving on to greener pastures, we end up like nobody else cares and nobody else is doing it.
And that's the thing with public health, that we don't really work in a bubble. We're all connected, especially like New Orleans, I feel like.
Right. But there have been things that are somebody's pet project, and when that person leaves, the pet project leaves with them. And we've all, like anyone who's been in the working world has been there, and they're like, hey, what's happening with X, Y, and Z? And they're like, well, she left, so I don't care. So we don't want anybody to feel that way about this. So we put together the Health Equity Action Team. And this team is made up, I had an explanation of what it was, but that didn't print. For some reason that slide didn't print. So my notes, I'm just going to go off the top of my head. We have about 15 people on the group, like 12 to 15 people on the group, several of which are staff people of Bureau of Family Health. We had to apply to be a part of it. Sumrita and I are both on the team, so is Shokfe. So we don't just have Bureau of Family Health folks on it. We have a couple of community members involved on our Health Equity Action Team. And we've also just made a call out to expand our action team to include work groups on specific topics. So our goal for this action team was to learn more and then make some processes and policies and put them in place so that we're all doing this. It's just part of what you do. If you work for the Bureau of Family Health, you're going to do these things. So we came up with a vision. Our vision is true equity in our health programs, policies, and outcomes for all. That took a while. We spent about 6 to 9 months just figuring out what we should know, doing some assessment of where we're at right now, assessing our staff, finding out where they were, like how many people had trainings, how many hadn't. We found out that a lot of the equity talk was really just the people who worked over near the Superdome in Benson Tower were all like, yeah, gung-ho about it, but it was not permeating outside of out of that Benson Tower building, and some of it went over to Baton Rouge, but not much. But for the people who are working day to day with the people, like our actual clients, we have a lot of staff that these people in the field that's home visiting, it wasn't getting to them.
I think it's helpful to add, you guys have like 300 and something staff.
Yeah, we have
across the state.
Yeah.
So just for those who don't know.
Right. It's huge. So it was really important to figure out where we were before we started saying, why don't we all go to a training in New Orleans? Like, no, that's not going to work. So what we did was we pulled together after about 6 to 9 months of learning and researching and figuring out who we were and what we needed to do. We had a facilitated planning session. And at the facilitated planning session, we came up with, we explored what other things we did was exploring what other states were doing about race and racism to address birth outcomes and infant mortality due to racism. We came up with a work plan and had that facilitated planning session. And what we decided to do was focus our work on these 5 areas, which are internal capacity, and internal capacity is like staff training and development, what's in your personal work plan, how you're reviewed, how we hire people, how we recruit people. So it's all related to human resources for the most part. Then community engagement. Are we engaging community? Are we just researching them, or are we actually involving them at all levels of what we do? Our data, our communication, and our policy. So not just our policy, but how do we influence policy at the leadership level? Since we are in the executive branch of government, we should be able to trickle up some ideas without it being lobbying. So
I'll go over what our data subgroup would cover, or will cover. We will look at supporting collection of race, ethnicity, and language data of underrepresented communities. Incorporate social determinants of health to reduce bias and unintended consequences, evaluate data communication to ensure appropriate language, presentation, etc. And then we're going to be using a checklist that both communications and data people will use, and create mechanisms to engage the community members and partners in all phases of data collection. And we think that's really important because I'm sure even as students you all have heard when researchers, public health people go into communities and then gather data and don't actually share it with the community, and their community is left wondering what happened. So it's really important to engage the community members, and then just reassess and evaluate our goals and objectives, just to just part of M&E.
Monitoring and evaluation.
Yes. Sorry.
And then on the communications, we don't have quite as many objectives, but they're impactful and they reach every part of the Bureau of Family Health. And that's the thing about data in the communications team, is that we work with everybody. So the things that we put in place are going to hopefully impact all the work. So we are also going to make an internal and external communication checklist to evaluate messages. We want to make sure that, someone from the audience we're targeting has actually, seen it and given us some feedback about our messages, so that we don't put words into somebody's mouth that are not like us. We want to make sure that we are believable, we're relatable, and that we also are not stigmatizing anybody. We're still in the process of that. We've started a basic checklist, but we need to start inserting some of those items into the checklist. At the supporting local and public health and other partners to advance health equity communications, we've actually started doing this, and this presentation is one of those, actually, activities. So thanks, Jokafe. We can say we did something. We actually just had a webinar earlier today too that was about effectively communicating with African American audiences and how to do community mobilization for communications work. And it was a little more in depth about some previous workshops we put on. Lynn Shea came to us and did the data and communication. So we want to keep those happening. And then we have a group called the Health Education Communication Functional Group that is an interdisciplinary group that gets together. See a couple members in here. I think what we want to do with that is make sure that that group also has access to any of the trainings that we're putting together, so it doesn't just stay in the Bureau of Family Health. And then beyond that, we also want to, when we do put out a call for proposals, which is our request for proposals. We have a couple that we put out every 3 years that we ask for the people who are making the proposals to include health equity lens in their proposals, that they're going to tell us how they're going to do the communications we need done, and also address health equity. So those are some things we're putting in place. And then once it's in a contract, that's institutionalized, because people look at previous contracts. If I'm not there anymore and someone's like, oh, let's write the next RFP, they'll say, let me see the last one. And usually that's how we build our RFPs, is to see what we did in the last one. So hopefully that will stick around for a long time. So that's the mostly the end of our presentation. And in summary, you want to do anything in summary?
So yes, we're still learning, and we're trying to take the things that we've learned and operationalize them, and we really hope that you're able to get a good sense of what we're doing and maybe take that over to your work that you do. And yeah, I think that's it. Any questions?
Yeah, and we also want to share with you a couple of resources, because like we said, we're not the experts, but if you want to look at any of the cool reports and the evolution of our reports, you can go to partnersforfamilyhealth.org and go to the data center. It'll link you to a place where you can find all of our reports, and that's actually going to get better and better over the next year, because we're doing some fancy stuff with it. And then some national resources, we mentioned AMCHIP. We've had a couple of technical assistance projects with them, and it's a great resource for life course theory and a lot of great things. Evergreen Data is one of our favorites. Sign up for her newsletter, because she is all about data visualization.
She's great.
Glennis Shea is with the Konopka Institute at the University of Minnesota. I don't have a better website for her. She's provided some trainings for us around communicating, and especially she's got a background in mass communications. So she's a really great resource, because she's been working in adolescent health for a long time, and she's often tapped as an expert in the field. And then MEE Productions is who does a lot of our workshops related to communicating with effectively with African American audiences. So, all right, now it's Q&A.
Oh, she's actually leaving. I was addressed.
Alex.
Oh, well, okay.
Stay.
Can't go.
To add to one of your resources, Kamara Jones is actually the leader in this field.
Oh, yeah.
When it comes to health equity. There are frameworks that are in the process right now at a much higher level. I'm going to speak as a public health professional and not a person of the CDC, even though that's where I work. For you, when you ask the question, are there frameworks that look at social determinants and look at the health disparities and so forth and how we present the data? Right now, yes, it's in development. There is intersectionality occurring. I'm sure you've heard of intersectionality that we are realizing has not occurred when we look at life force theory, when we look at race and gender, when we look at critical race theory. We are taking, and even when it comes to sexuality. So there are mechanisms and work groups at the federal level that are taking place that will eventually start coming out and addressing the question that you have. The other thing is data is further down the road. What we found is we're not asking the right questions in the very beginning. And so we're finding the problem is perpetuating the disparities is how we ask the questions and who asks the questions. And what are we really trying to do? We're trying to be mindful and very thoughtful and anticipate how the data will be communicated and used down the road. So that will get at some of why data has been historically communicated in ways. The other thing is we have to have enough diversity at the table, at the federal level, where we sit and write what used to be called FOAs, and now NOFOs, where we sit and write that and include health equity and disparities and inclusion in for when we send it out to the local level. So now we're just starting to realize that we've been asking the wrong questions and haven't had the right people at the table, and the same people have been sitting at the table, and that's a problem. So I just wanted to let you know, keep fighting, get included, come.
Thank you. I want to put out there too, since part of our team is now children and youth with special health care needs, we've also talked about how to include the intersectionality with ableism and racism too, because that's a huge problem. And we are reminded of it on a regular basis that we are probably ignoring something that is huge that we need to start figuring out how to put that in there too.
And part of the language that we use is important.
You can go to the bathroom.
Sorry, part of the language we use is important. I'm part of the vulnerable population, so that's why I'm glad you were showing the face. I was like, I'm glad you heard that story about that report, but you see, it took 2 years to get it out. That was a nice rosy story that they gave you at whatever conference you went to. But there was a lot of behind the scenes from the vulnerable populations work group within the agency that said, wait a minute, we're conveying things and we're not being mindful of how people confront with this because we are aware of it. The other thing is when you use the word unintentional earlier on, there is a movement in public health that unintentional releases any agency from responsibility of the policies they set forth. So basically you're saying it's using, when you say it was an unintentional systemic racial policy.
That's why before I said it, I realized it's problematic. When we were going through this, I'm like, that sounds terrible. Because it was intentional. And that's why I said that before I said the words about the unintentional, because a lot of people don't realize and they think it's unintentional. When they pass it on, they may not know that it was intentional. So yes, do you have a suggestion for a better word?
Well, there actually will be guidance coming out because the problem is you don't want to have the agency absolve itself from structural racism. When it is perpetuating it at the same time through the workforce, if they don't have enough diverse workforce, if they are not engaging the community and so forth. So when we say unintentional structural racism, that's really not, we are still doing intentional structural racism. We're trying to undo it at the moment. The other thing is because policies manifest differently in a capitalistic
society. So you have to be, we have to be more mindful. I'm saying this to all of the students in here. We have to be more mindful, because even though we're trying to undo it at a structural level, capitalism redlining may be illegal now, but we just saw Wells Fargo and Bank of America did redlining and still are perpetuating structural racism.
And some of those laws are actually still on the books, and people say, well, we're not enforcing them. I think it's still problematic that they're there. You know, if someone wants to literally read the law and follow it, it's there.
So I just want us to be mindful when you see unintentional, because I had a visceral reaction.
Yeah.
So,
it's okay. I did while I was saying it too.
So, to take it outside the silo of public health, I really appreciated the activity of redoing the headline and the subheadline. I think it could be really awesome if you guys did trainings for media. As someone who used to be in media, you know, you may get some pushback at first because there may be some ego there, but I really, really think that that's important.
That's a great idea.
Especially as like the burden or the quotas that reporters are getting, they're just making snap decisions. They're not thinking through those headlines when they post something real quick online.
And that's part of our checklist too, is when we're helping put together a press release, it's not just, it doesn't just go through our department, it has to go up to the Louisiana Department of Health and the Bureau of Media and Communications. Luckily, we have a seat at the table with them and a good relationship, so we're actually trying to get them, once we have our checklist, we want to move it up to them as well, because that's exactly what that is. And if anyone needs an expert to do that, that's what Glynis does for a living, so she's a perfect fit for that, and I think it would be great. You just need the news media to want to do it.
Just got to find a way to engage them.
Well, reporters are so freelance. So there are barriers that you need to figure out how to overcome them. So those are the things to take into account. I think people would want to do it, though. Okay, anybody? I think there's 5 minutes left of you get some 5 minutes back. Thanks.
Thank you so much for attending.
I think there still might be 3 minutes.